you very much, Professor Abdullah, Professor Rosano, and Dr. Nadia. It's really an honor to continue in this very important theme, and I'm going to talk about when the echo lies and the RV hemodynamics speaks. I changed it a little bit so it can be a little bit more practical. So pulmonary hypertension is clearly beyond the echo assessment of right ventricular pressure, and often the echo will give you the wrong answer if you don't do it properly, and you do have to assess right ventricular hemodynamics. So I'm going to make it very easy. Echo is not enough in pulmonary hypertension. There are multiple echo guidelines. I've listed 3 of them here, the European, British, and the American Society. Detailed echocardiographic assessment of the pulmonary hypertension, and RV is a must. You cannot just look at the RVSP and expect not to miss this disease. This is the QR code if anybody wants the slides. So all the honoraria are donated to patient-supporting charities in UAE. So remember, pulmonary hypertension is a misnomer. It's not a blood pressure issue. It's a lethal cardiopulmonary disease with mortality up to 30% more than cancer. The victims of this is right ventricular failure and cardiogenic shock, often too late. Young females after their first delivery are the victims of this lethal disease, and the diagnosis is a major challenge. Hidden, progressive, deadly. So don't forget it and look for it. We are cardiologists, we can see this. It's not difficult. The victim here is the right ventricle. So the pulmonary arteries change and become smaller and smaller. This causes right ventricular failure and death. So we're going to say the right ventricle is what we need to look at, not just the pressure. We must look at the right ventricle, right atrium, and all of the factors. Now the problem is it's a confusing disease in terms of symptoms. You have patients going to neurologists for dizziness, electrophysiologists for arrhythmia, heart failure specialists, but sometimes they can even go to a gastroenterologist because of ascites. The combination of cough, shortness of breath, dizziness, and these vague symptoms in young people is where you should do a proper echo. And the confirmation is right heart cath and the treatment after right heart cath. Don't treat by echo. Death within 3 years is guaranteed if you don't pick up these signs. 3 years. So this is the risk stratification algorithm, and the 1-year mortality, 20% or more if you have any of these features, which I will not go into in detail. Even the intermediate risk patients, 19% mortality. Even the low risk patients, 5% mortality. It is imperative to make the diagnosis and do it properly. So I was privileged to work with Professor Abdullah Shahab, who was on the steering committee of the publication. We were able to do a 2025 consensus of all of the 3 societies for pulmonary hypertension management. There are 46 experts and authors. Professor Abdullah Shahab also is the lead on the authorship here, as well as the editor of the main guideline. So I'm not going to show you all of it. There's 12 chapters. It's available online. Now, pulmonary hypertension is a hemodynamic diagnosis. Right heart cath is a must, not optional. A must, not optional. I'm going to say it one more time. When you have a suspicion, you need to do all these measurements, because the definition is based on pulmonary artery pressure measured, as well as the wedge pressure measured, as well as calculated pulmonary vascular resistance, PA compliance, and many other features. And the measurements have to be done accurately. This is not a pressure measurement. You have to make sure you're calibrated, inspiration, expiration, diastolic parameters. It is recommended to support treatment. It has to be performed in experienced centers with a complete set of measurements. This is not an expensive echo, and calculations. And vascular activity testing, very important, using nitric oxide or iloprost. If you're not able to do all that, reference center. These are all the measurements that need to be done, including calculations of cardiac index, PVR, and assessment of shunts and vasodilator challenges as well. In the European guidelines, if you have a patient like this, fast track to a PH center for right heart cath. In the UAE guidelines, this is one of the guidelines that Dr. Abdullah Shahab was leading with us. Again, you take the patient to a PH center. Right heart cath is the center of the diagnosis. It's being stated hundreds of times. I still see patients being treated empirically with echo or not getting a right heart cath. So let's start with echo. I didn't mean to say that echo is not good. Echo is a good screening tool. What is everybody accustomed to getting is the TR velocity. Yes, it's an estimate of right ventricular systolic pressure, but it's truly an estimate. In these studies, it shows that correlation with right heart cath is only 50%. You can be high or low. If you get the wrong number, say patient doesn't have pulmonary hypertension, they die. You need to have a suspicion and send to right heart cath. This is the false negative. At least 25% of patients are detected as false negative by RVSP alone, i.e. you don't see the RVSP. This is a big mistake. TR velocity is not always accurate. It depends on the envelope. If you have a nice strong envelope like this, it's different than one like that. And you're estimating. This is a serious disease. Estimates cannot be used. Look at this. This is the distribution of RVSP versus right heart cath. You can have patients with a normal RVSP with a very high. Why? Because there's not enough tricuspid regurgitation. So how do the guidelines solve this problem? Since 2015, they are telling cardiologists, look at the right ventricle carefully. And also look at the right atrium. And look at the IVC. If the right atrium is dilated more than 18 square centimeters, there is a strong suspicion of pulmonary hypertension, even if the TR velocity is not elevated. Look at this, less than 2.8 or not measurable. Any of these findings that suggest RV, dilatation, enlargement, RA, dilatation, enlargement, PA dilatation, pulmonary hypertension is still present, and you need to find it. Look at that. If you're not doing this, you're harming the patient. The RV needs to be measured not just by pressure. This is the updated 2022 guidelines. It's the European Society of Cardiology Echo Guidelines. All 12 functions have to be measured and documented for you to prove the patient has or doesn't have pulmonary hypertension. And if you didn't believe me, same thing. Even if the TR velocity is low, if any of these chambers are dilated or abnormal, pulmonary hypertension exists, go to right heart cath. Low threshold for right heart cath. So the American guidelines have said exactly the same thing. This is updated. Again, if you have any of these criteria, dilated right atrium, acceleration time, IVC dilatation, proceed to right heart cath. So echo is not enough in PH diagnosis. The guidelines recommend that the echo assessment is limited to probability. If it's even likely, send to right heart cath. And in patients in whom PH requires confirmation, even if it's a lesser risk, please send to right heart cath. It's an incredibly safe procedure. We do hundreds of these a year, and it's done with brachial venous access. It's almost atraumatic. So again, TR velocity is high, you have the answer. Not high, look at the other echo criteria. If any of them are abnormal, you have not excluded RV dysfunction due to pulmonary hypertension. So this is a typical echo report just to show you. What's missing here? Takes about the LV, gives you ejection fraction, mild TR. Is this enough? No. What's wrong here? Hidden behind the mild TR is dilated RV, impaired systolic function, reduced TAPSE, and the TR velocity of 4.4. So don't make this mistake. This you cannot miss. Even if they tell you the TR velocity is normal, what's wrong with this? D-shaped septum, massively dilated RV, massively dilated RA, small left atrium, right? This was proven in this evidence-based study. They took 550 patients, gave them all right heart cath, and looked at the echo. 39% of these patients had an echo that showed a TR velocity less than 2.8, yet they all had pulmonary hypertension by right heart cath. So what's the answer? Right heart cath, right? This is a key component of the mistake that everybody makes, and I've been here for 14 years, and every single patient I have has this issue. So the TR velocity, of course, is important. If it's elevated above 2.8, this is pulmonary hypertension. Next, how do you measure it? You line it up and you take the velocity. But of course, this you don't even need to do a TR velocity. What's seen here? Massive RA and RV dilatation. This cannot be anything except pulmonary hypertension. Now, this is a typical echo envelope, right? You see this all the time. So what number is it? Are you going to give it 300 or 200 or 100? Which one? It's going to have a lethal consequence if you don't do it properly. So the reality is we had the technicians go back and get a very nice envelope, and we are getting the same patient, 77. But you can fool yourself and put in any number. If you cannot see the number, do more measurements. Now, if it's not clear or the patient doesn't have TR, which is common in the early stage patients, right? They don't all have fulminant severe RV dysfunction. Do a bubble echo. The echo signal can be used to make the envelope clearer. Here you can barely see it. Now it's very clear that this is 4 meters per second. Don't miss this opportunity in your clinic. This is a lethal disease. We need you to send us more patients with right heart cath. Dilated pulmonary artery. How to do that? RV acceleration time. Dilated pulmonary artery cannot be missed. Everybody on the short axis view can see it. When you look at the right ventricular outflow tract acceleration time, put the pulse wave velocity right here and get this number. If it's a sharp acceleration time, this patient has pulmonary hypertension. If there's a W-shaped notch, it's pulmonary hypertension. It is more measurement for your technician, but you have to do it. You cannot ignore this lethal disease. PR velocity. If you can't get a TR, you can get a PR. PR velocity, diastolic elevated, means the patient has severe pulmonary hypertension. I need a couple of minutes. This is 2. 1, 2. Some. Better than nothing. Okay. Can we turn it on? Yeah. So, these are just how to measure. Very simple. Put the Doppler right there, the pulmonary valve. You can't miss it. In the short axis view, even our fellows know how to get this. And this is the flying W notch. So the D-shaped septum is another key point. A dilated RV shifts the septum towards the middle, and the right ventricle can never be bigger than the left ventricle. Remember this. Right atrial area. You teach your fellows how to do this. It's so easy. Trace the right atrium in the 4-chamber view. Anybody can do this. Literally, I can take a nurse and show them how to do this. If it's more than 18, you have a pulmonary hypertension until proven otherwise, or an ASD, or something like that. Something's wrong, don't ignore it. Dilated IVC, our critical care colleagues do this all the time to assess volume. If you have a dilated IVC in a breathless patient, pulmonary hypertension is there. One other important point is TAPSE. Please do this. This is dead easy. This is literally M mode in the lateral right ventricular axis. If it's low, this is a patient with dysfunction. And this is now validated in the guidelines to prove prognosis. If you take the TAPSE and you divide it about the TR velocity, you have something called the TAPSE-SPAP ratio. If this is low, this is a severe pulmonary hypertension who's going to die. And if it's less than 18, this is a patient who needs a transplant. So please do these numbers. You can't afford to miss this. This is a lethal disease, and the more we do for the patients, the better. So these are pericardial effusion. Don't forget right ventricular size and function. Detailed RV is very important to assess the probability of pulmonary hypertension. Confirmation with right heart cath is warranted for definitive diagnosis. Do not treat patients without a right heart cath. I promise you this is an outpatient procedure that takes literally 30 minutes, and then we make a treatment decision. But all before that is to do an excellent right ventricular echo. Don't miss the findings. We're cardiologists. We do the imaging. Big PA, big IVC, big right atrium, even if the TR velocity is not elevated. And if you're not sure, do a bubble echo to enhance it. Thank you. Thank you for the 2 minutes.